Today, we're going to talk about something very different. What we're going to discuss is electroviscerography in its role in endometriosis when married to a clinical support tool known as an AI-derived threshold score of the intra-abdominal myoelectrical activity, predicting the presence and spectrum of disease in endometriosis. You see my disclosures there. This all began in 1998 from research done out of Women's Hospital in Texas by Dr. John Mathias, a fellow gastroenterologist. This was published in Fertility and Sterility, as well as with a well-known gynecologic surgeon, Robert Franklin. And what he discovered was that they had a very unusual contractile pattern to their small bowel that he could find in no other disease process. Not only did he discover this very unusual contractile pattern, but he also found it was due to the degree of prostaglandins secreted by endometrial tissue. And that's where this all began. The mechanism of action is actually quite simple. The endometrial tissue produces large amounts of prostaglandin E2 and F alpha. It doesn't matter where this tissue is. It can be in the pelvis, the abdomen, in a joint space, in the brain, paraspinal, thorax. The substances are absorbed, carried through the circulatory system. When they pass through the circulatory system, it has a very unique effect on the small intestine. It causes seizure-like opposing contractile activity of very, very high frequency. And this is what Dr. Mathias, what John had been picking up in his studies. The interstitial cells of Cajal, by the way, since we're talking about pathogenesis, discovered by the Spanish anatomist Ramon y Cajal, who, by the way, was the only Spanish physician to ever win the Nobel Prize in medicine. That was back in 1907. Discovered these interstitial cells that sit between the myenteric plexi, as well as the smooth and the longitudinal muscle. This is true for all parts of the body that have smooth muscle. And these are the keys. These are your regulators. This is what keeps things contracting normally. And these are the things that are most affected by the prostaglandins. They are the pacemakers of all smooth muscle and gut homeostasis, which is normally maintained from those. The gastric frequencies are between 1 and 10 cycles per minute that we can measure, and bowel frequencies are between 10 and 15 cycles per minute. ICCs also control all of the GYN organ contractility. Of course, these are also hormonally influenced, but the uterus and the fallopian tubes typically, when not active, contract at about 1 to 2 cycles per minute. During menstruation, this will kick up to 5 to 8 cycles per minute in the uterus, and the fallopian tubes during ovulation and follicle development will kick up to about 8 to 12 in preparation for egg transport. So when the endometriosis tissue secretes the prostaglandin E2 and F alpha, it creates these spastic opposing contractions, and it essentially uncouples the contractile control, the governors, the ICCs. And this occurs in a typical drug dose response pattern. So the more tissue, the more prostaglandin, the greater the reaction. The less tissue, the less the reaction. The less active the tissue, the less reaction. Now, what it does in the small bowel is it creates uncontrolled small bowel activity between 15 and 200 cycles per minute, but very particularly in 3 particular ranges, which make up, it's almost like a fingerprint of activity in the 15 to 25, 30 to 40, and 50 to 60 cycle per minute range. And this is unique to endometriosis, according to John's findings. So in 2007, John came to me and said, look, you've already invented another device that looked at gastric motility and small intestinal motility. Could we open up the filters and take a look at what's happening in the small bowel so we could track endometriosis? So what we did, normally we filter everything above 15 cycles per minute. We changed the algorithms, and so now we're filtering everything from 15 and below so that we can see the higher frequencies. And in homage to the Star Trek series, I called this the tricorder 3L. And not only can we detect this activity, but we can detect when it goes back to normal, which becomes very important because it offers us the prospect of seeing when drugs or surgery or other different modalities are working, when the disease becomes active and when it becomes inactive or returned to homeostasis. This is the device. It is a very, very simple device. You see here, there's a respiratory belt that's placed above the clothing, above the breasts in the patient. It just sits there loosely. All this is doing is sensing respiration and telling the computer that when you're breathing 25 times a minute, that's not a bowel contraction. The main heart of the device, the tricorder device, is about the size of 2 cell phones put together. And this is really the heart of the system. It senses, it filters, and it interprets the signals coming out of the abdomen. And then another key point to this are the 3 electrode pads. And this literally is the entire system. These electrode pads are special. We are all used to seeing electrode pads with the 1 centimeter liquid center. Those would be the liquid gel electrodes. The problem is you can't leave them on for real long periods of time without losing connectivity. They're fraught with increased artifact, and which we need to eliminate artifact. And we also need to sense very, very low frequencies, not like cardiac frequencies. And these are placed, as you can see, on the abdomen, and the entire test itself, the standard water load test sequence, which was developed in the GI world, is the patient will come in after a overnight fast. It can normally be an 8-hour fast. It can be 6 hours for diabetics or those who cannot tolerate 8 hours worth of fasting. They're allowed to have a 200 kilocalorie meal about 2 hours before the test. That means a slice of toast and some apple juice, or those who are gluten sensitive, that would be 2 rice crackers and some apple juice. The electrodes are then placed on, and they must remain in place for 10 minutes to increase skin conductivity. The device is connected, and then after a 10-minute baseline period, the patient does nothing more than drink a glass of water until they're full. That is the entire test. They then remain in a reclining position, and during that time, the device will detect the myoelectrical signals coming up out of the abdomen, and then they're immediately put into the AI-derived program, and you have an instant analysis. So 30 minutes after you drink water, you have a diagnosis, endometriosis, yes or no. Now, of course, when you do something like this, you've got to look at what your normals are. No one had ever looked at normals in the 15 to 200 cycle per minute range. So we studied roughly between 3,000 and 4,000 patients from 2007 to 2015. We looked at men, and this is a male. You can see here in the critical frequencies of 20 to 70, there's really not a lot happening. Men typically are reactive in 120, 140, and 200. And that's a little bit different than women, normal women. And what you see here is a peak in 80 to 90, 160 to 180, but nothing again in this 15 to 70 range, just some random activity. And so once we established the normal, and by the way, when we did these normals, we tested every disease known to man or to woman. Inflammatory bowel disease, Crohn's, ulcerative colitis, IBS, ulcer disease, gallbladder disease, liver disease, polycystic ovary, pelvic inflammatory disease were all included. Other biliary tract diseases, as well as urinary tract disease, ICC, everything that we could test, we tested, and nothing other than the endometriosis patient had the very specific signal, which you see here. And this is very characteristic. So when I talk to you about the fingerprint, the characteristic fingerprint that we detect, that's it right here, 15 to 25, 30 to 40, and 50 to 60 compared to your normal up here. And that's what we see every single time when there's a patient with endometriosis. Now, of course, there's a problem with using a test like this as a diagnostic. It's difficult for people to agree on squiggly lines on a screen. You're inevitably going to have people scrunching up their eyes and twisting their head, and arguments over what's positive and what's negative. So you really have to take this to a quantitative level, which means you have to look at area under the curve. And when we look at the actual energy generated by the area in the area under the curve, you can see there's quite a difference here. Here's your endometriosis group, and here's your normal patient group. And there are factors of 50, 60, 80 here in all of these frequency ranges. So we knew we had something that we could track, and this is something we could then quantify and do our studies. So getting down into the actual data on the study that we performed, we created study with 154 patients. Cohort 1 were non-endometriosis controls. These consisted of a blended cohort of normals. These were normal, healthy women without symptoms. And then there were women who had abdominal pain, not from endometriosis, but from other known causes. Cohort 2 was our gold standard group. This would be laparoscopic surgery with positive biopsies, no therapy. And then cohort 3 was the proof of concept group, or your validation cohort, which were women who were being seen in the practice there at Texas Women's, who were coming in for preoperative evaluation with this device, who had suspected endometriosis due to causing their abdominal pain, who then went on to have surgery. When we look at the demographics of all 3 cohorts, as you would expect, the most important change is that there were significant differences in pain scores. The normal patients had significantly lower pain scores than the 2 endometriosis cohorts. One other difference was there was no Asian in our normal cohort. but the remainder of the ethnicities remained balanced. It made no difference what the BMI was, nor did it matter about bloating. Now, because it was a blended cohort, it was really important to take the normals, we'll call them the healthy normals, and compare them to the patients who had pain from other causes, but not endometriosis. And when we did that, we found that they were a statistically identical group. So we could combine them to be our larger normal cohort. As you can see here, no statistical difference between those two groups. The numbers are cohort 1, 62 patients in the normal group. None of those 62 had the qualitative pattern that we would typically see, that fingerprint that we would typically see for endometriosis. Cohort 2, which was the gold standard group, consisted of 43 women who had, every one of them had that qualitative pattern, that positive fingerprint. And then in cohort 3, 47 were positive for that qualitative pattern. 2 were negative of the 49. And when they were taken to surgery, 47 who were positive came back with the diagnosis of endometriosis, and the 2 who were negative with our test ended up having no endometriosis. All 4 ASRM grades were present, although the grade 3 and grade 4 were slightly increased in number. So now we go and we compare the data between our normals and our 2 endometriosis cohorts. And as you can see here, we have significant differences between cohort 1 and 2, as well as cohort 1 and 3. Now, we also, in the paper that's been submitted to the Green Journal, that we hope will be out fairly soon, we also did compare cohorts 2 and 3 and found them to be statistically identical also. So we knew we had significant differences with this, again, non-invasive test. So the next thing we set about doing was estimating sensitivity, specificity, as well as looking at the predictive capability for diagnosing endometriosis. In order to do that, the classic way is you look at area under the curve, which is what's used mostly for predictive probability. And that was our initial covariant. We look at that covariant value at all points in time of sampling, which was at baseline, 10 minutes after water load, 20 minutes, and 30 minutes after water load, and at all frequency levels. We add in a logistical regression analysis because we're using an AI-based formula to help in analyzing and making sure we have significance. As well, we employed the AI to look at other variables. So we were using 3 variables: age, pain, and the AUC as the covariant. And this gave us a predictive probability or extent level of 0.5 that we use as a basis for determining who had endometriosis and who did not. AI is a fairly new field. And so how do you determine whether your AI could even be considered appropriate here? One of the ways is you use an extent level of 0.5, and the other way is you use the rule of 1 to 10. So you must have 10 to every single variable. We had 4 variables that we were analyzing. Therefore, 30 women would have been sufficient to run AI analyses. And then the other thing I happened to notice was, as I was analyzing the data, there appeared to be a 4% difference when we looked at the age grouping 35 and under and 36 and older. And I felt it was important so that we didn't see the better data in the 35 and under trying to make the 36 and older look better. So we separated that in our analyses. Now, these are the ROC, the area AUC of the ROC curves. The goal here is to get as close to a value of 1 as possible. They're separated by the 2 age groups. That means we want to get as far into that left upper quadrant as we can get. And the value for the under age 33 group was not quite 1. It was 0.9949. And again, we were off by a small factor, variability with the older patients, and they were 0.9. Can't really read that from here, 0.947. So we knew that we had a very significant predictability. And so then we took a look at the specificity and sensitivity in these 2 groups. Now, these are some of the variables that we looked at, and we ended up settling on the area under the curve from the 30 to 40 and 50 to 60 group. 40 to 50 group, as well as looking at pain symptom scores. You'll notice here when we look up at the 15 to 20 in pain symptom scores, they're pretty much the same. However, there's another feature that we need to know, and that is that I can diagnose gallbladder disease with this same tool. Biliary tract disease comes in at frequencies of 12 to 18. And I didn't think that false positives were going to be acceptable in this particular group. We wouldn't want to have anyone operated on for endometriosis who really had gallbladder disease. So we excluded those frequencies, which is how we arrived at the higher frequency levels. And as you can see, our sensitivity is 95%, specificity 96%, and our C statistic, which means the probability that someone who has a positive test will have the disease, was 99 plus percent. That does change when we look at the 36 and olders. Remember, I had mentioned there's about a 4% variability. So our sensitivity drops from 95 to 91%. Our specificity goes from 96 to 95. And we do have a slight reduction in the C statistic from plus 99% to 98%. This is an example of the endometriosis clinical support tool that comes along with the device itself. So the device is an FDA cleared device that detects the myoelectrical activity of the gastrointestinal system. That's what provides the data. And then this is the clinical support tool, which, by the way, for those who are interested in regulation, is not regulated by organizations like the FDA. In fact, it's strictly unregulated. And we plug in, and on the left-hand side here, this is the light switch is on or off. This gives you an idea. Does the patient have endometriosis, yes or no? The values that we place in here, as you can see, are the different time levels and the 30 to 40 and 40 to 50. We place in age as well as the patient's symptom score. And then you look down here, she's 43, age greater than 43. Her value is 0.5. She does not meet the P range. And her activity score, which is the second thing that you see here, is 0.2833. And normally that would have to be 0.5 or higher for her to be positive. So this is a patient who would be negative for endometriosis. And the combination of the two scores being negative validate her as negative. And then if we do give a range of values that go from 0.4 all the way up to 1. And this gives us an idea of the severity or the activity index of the disease, which we felt at one point may be tied to the ability to predict the staging of the disease. In fact, we did take this out to a center on the West Coast, a MIG center on the West Coast, and these are the 9 patients that we did. The first 2 were our control patients, and the bottom ones were patients who underwent the study. The bottom 7 underwent this study, were positive, and then went to surgery within a 3-day period of time. And what's very interesting, you'll notice here that those in the surgical grade 4 group all had scores of 0.9 and higher. Those in the 3 were 0.7 and higher, and those in the grade 2 were 0.66. This cohort, of course, is quite small. This is only 9 patients. We have about 400 patients in this cohort. We're not ready to publish it just yet, but we seem to be tracking the disease activity or the disease severity. In conclusion, qualitatively, we have about 100% sensitivity, specificity, and surgical concordance when you're just looking at those diagrams. However, when we get down into the quantification, again, we're at plus 99% for a C statistic for the age 35 and under, and 98% accuracy in diagnostics for those 36 and older. And by the way, all of the women in the endometriosis cohorts were on hormonal suppression for a minimum of 4 months prior to their diagnosis of endometriosis. And so that would be either birth control pills, a Mirena IUD, or gonadotrophin axis blockers. What we have is a non-invasive test that can become a diagnostic standard based upon the AI-derived threshold. We can screen from menarche to menopause. The evidence is objective, it's rapid, it's completely non-invasive. The value in post-surgical evaluation, post-surgical follow-up, post-medical therapy follow-up needs to be evaluated. We have some anecdotal evidence that the levels do fall significantly depending upon how much tissue is removed. It may change the diagnostic algorithm for those of us involved in reproductive areas. Pelvic pain, 70% of the patients coming in are known to have endometriosis. We can show you the 30% that don't, and that will change what you do with them. What's near and dear to my heart, although, are the adolescents and the young adults who typically wait 8 years to 12 years to get a diagnosis, when we know for sure that 45 and 55% respectively have endometriosis associated with their dysmenorrhea. This test is available to them to get that diagnosis now, instantly, instead of waiting multiple years. We believe that this is complementary to the current anatomical staging. We are providing a graduated activity index level. It will need to be validated with considerable and future research efforts at various centers. We believe that our numbers reflect the spectrum of disease activity or disease burden, which will help again with the post-treatment monitoring and effectiveness of therapy, and should allow us to see a plethora of new drugs developed now that there is a non-invasive test that can test the effect of those drugs. Finally, this is a very low cost and portable test. Literally any small village on the side of a mountain or in the middle of the desert, if you've got access to potable water, a computer, and a chair that reclines, you have a diagnosis for endometriosis in 30 minutes. It is resource non-intensive. It requires nothing more than a medical technician to do these studies. It would be a waste of financial resources to use a physician or a nurse or even a physical therapist, who are very expensive to do these tests. And the other point is, no tampons, no menstrual fluid, no biopsies, no urine, no blood, nor is there any saliva required to do this test. And nor do you need any laboratory services, which keeps the cost really low. How low is the cost? The consumable is $43, and that's the cost of your test. So we essentially have decentralized this disease. We've decentralized the diagnostic capability for this disease, and we've eliminated those unintentional geographical and financial factors that cause discrimination and lead to delay in diagnosis.